welcome back to our channel. Today we're going to be going over chronic kidney disease. So here's our board for the day. To begin with, we want to go over what actually defines chronic kidney disease. So with that, you can look at the features. So that's going to be a GFR decrease that has been at minimum 3 months or greater. So moving down to the causes of chronic kidney disease, there are going to be 4 main ones. So we have diabetes mellitus, chronic glomerulonephrotic disease, polycystic kidney disease or PKD, and APOL1 nephropathy, which is hypertension, and this is typically seen in African American men. Moving down to diagnosis, so the big things are going to be that GFR as well as microalbuminemia. So now with the treatment, the biggest thing is going to be controlling the blood pressure, so putting your patient onto an ACE or an ARB as needed. And then really you just have to wait it out. You want to just kind of decrease the progression of that chronic kidney disease as much as possible and deal with the symptoms that are occurring in your patient. Another thing is you want to control the fluid intake and overload, so you just really want to monitor that. And then just protect the veins as well. So there is different staging that goes along with chronic kidney disease, and so we're going to go ahead and have Shannon jump in. She's going to review that for us today.
Hello. So depending on where you look, if you look on UpToDate, the staging for chronic kidney disease, also known as chronic renal failure, they have kind of a XY axis staging system where they combine GFR and microalbumin. But for the purpose of this class, we kind of learned it just as GFR, and I think some nephrologists may go off of that. So I'll go through the staging in terms of GFR only. So we have CKD 1, 2, 3, 4, 5. Stage 5 chronic kidney disease is also known as end-stage renal disease. So chronic kidney disease stage 1, this is when your GFR is above 90, so it's within range, but you have evidence of kidney disease, which essentially means you have microalbuminuria. And then CKD 2 is GFR 60 to 90, CKD 3 is 30 to 60, or 59, CKD 4 is GFR 15 to 30, and then end-stage renal disease is GFR less than 15. So the next question for primary care providers, when should you refer to a nephrologist? I believe when a patient is either in 3 or 4, I'm not totally sure, but I think less than 3, at that point you definitely want to have a nephrologist on board. CKD 5, end-stage renal disease, there's 3 ways you can treat this. The first is a renal transplant, and the second is hemodialysis, and the third is peritoneal dialysis. We'll go through dialysis in another video. Something I also want to mention just real quick is microalbuminuria. When we're talking about this, there's pretty much 2 different ranges. So less than 30 is how much microalbumin, which is protein, you want in your urine, because really we don't want any protein in our urine. So less than 30 is the goal, but if your patient is urinating protein, which is a problem, 30 to 300 is moderate microalbuminuria, and then 300 plus is severe microalbuminuria. So we follow this definitely with chronic kidney disease as well as diabetic nephropathy. We want to follow this really close, so just kind of remember, microalbuminuria, never a good thing. There should never be protein in your urine. That is pathological, very pathognomonic for renal diseases. And then 30 to 300 is moderate, and 300 plus protein in your urine is severe. Thank you.